Cabometyx, cabozantinib, in combination with nivolumab, is indicated for the first-line treatment of patients with advanced renal cell carcinoma, RCC. Select important safety information. The full prescribing information for Cabometyx includes warnings and precautions for hemorrhage, perforations and fistulas, thromboembolic events, hypertension and hypertensive crisis, cardiac failure, diarrhea, palmar-plantar erythrodysesthesia, hepatotoxicity, adrenal insufficiency, proteinuria, osteonecrosis of the jaw, impaired wound healing, reversible posterior leukoencephalopathy syndrome, thyroid dysfunction, hypocalcemia, and embryo-fetal toxicity. Additional important safety information will be presented in this video.
Hello, I'm Dr. Daniel Geynisman, and I'm a medical oncologist specializing in genitourinary cancers. Over the past decade, we've seen an enormous expansion in treatment options for patients with first-line advanced renal cell carcinoma. My research focuses on health outcomes and clinical trial development in GU cancers. What drives my work is a deep commitment to improving not just outcomes, but the quality of life for every patient I care for, and it has been particularly satisfying to see the rapid progress in advanced RCC over my career thus far. In this video, we will discuss Cabometyx and Opdivo, an approved first-line combination treatment in advanced renal cell carcinoma, or RCC. I will present data from the Phase 3 CheckMate 9ER trial and will share what I believe is the most compelling data for this TKI and IO combination therapy. We'll cover topics such as the efficacy and safety endpoints from the primary analysis, 5-year minimum follow-up analysis, discontinuation rates, dosing, and other exploratory analysis such as overall survival by sites of metastases, PFS and ORR data in patients with grade 3 or higher treatment-related adverse events, and quality of life considerations. Let's review the study design of the clinical trial. CheckMate 9ER is an open-label, Phase 3 randomized trial of treatment-naive patients with advanced renal cell carcinoma with any clear cell component. Patients received either Cabometyx, 40 milligrams orally once daily, plus Opdivo, 240 milligrams IV every 2 weeks, or sunitinib at the standard schedule of 50 milligrams orally once daily for 4 weeks, followed by 2 weeks off. Patients were treated until disease progression or unacceptable toxicity occurred. Median follow-up of the primary analysis was approximately 18.1 months. We will also review data from the minimum follow-up of 5 years as presented at ASCO GU 2025. The primary efficacy endpoint around which the statistical plan was built was progression-free survival. The secondary endpoints were overall survival, objective response rate, and safety. PFS and ORR were assessed by blinded, independent central review. Health-related quality of life was an important exploratory endpoint. CheckMate 9ER studied a range of patients, including those with a high burden of disease similar to those we see in our daily practice. Most patients enrolled in CheckMate 9ER had 2 or more sites of metastases. If we look at the breakdown, 75% of patients enrolled in CheckMate 9ER had lung metastases, 23% had bone metastases, and 19% had liver metastases. Almost 80% of patients had IMDC intermediate or poor risk disease, with 19% having poor risk disease. Also, nearly 30% of patients had no prior nephrectomy. Next, we will review the efficacy and safety results of the CheckMate 9ER trial, including the primary analysis and a median follow-up of 18.1 months and a follow-up analysis and a median follow-up of 67.6 months. In CheckMate 9ER, Cabometyx and Opdivo demonstrated superior efficacy versus sunitinib across PFS, OS, and ORR in the primary analysis. When we look at the PFS data in the primary analysis, we see that Cabometyx and Opdivo doubled the PFS with a median of 16.6 months versus 8.3 months with sunitinib. In the 5-year minimum follow-up analysis for PFS, Cabometyx and Opdivo data was similar to the results of the primary analysis. The median PFS with the combination was 16.4 months versus 8.3 months with sunitinib. I believe long-term follow-ups such as this are important for me to understand the long-term results of a regimen, information that we can consider in real-world practice. It is also important to note that no formal statistical testing was conducted at the time of the updated analysis. When we look at overall survival in the primary analysis, it is encouraging to see the early and sustained separation in the curves. The hazard ratio was 0.6, and the median OS was not reached in either treatment arm. In the final pre-planned analysis of OS at a median follow-up of 32.9 months, the median OS with Cabometyx and Opdivo was 37.7 months compared to 34.3 months with sunitinib. When we look at the 5-year minimum follow-up for OS, the median OS with Cabometyx and Opdivo was 46.5 months compared to 35.5 months with sunitinib. Additionally, at the 2-year landmark analysis, 70% of patients on Cabometyx and Opdivo were alive versus 60% of patients treated on the sunitinib arm. At the 3-year landmark analysis, 59% of patients on Cabometyx and Opdivo were alive versus 50% of patients treated on the sunitinib arm. And at the 4-year landmark analysis, 49% of patients on Cabometyx and Opdivo were alive versus 39% of patients treated on the sunitinib arm. And here, in the primary analysis, objective response rate was doubled in patients in the Cabometyx and Opdivo arm, where it was 56%, compared with those in the sunitinib arm, where it was about 27%. Of note, only 5.6% of patients had primary progressive disease with Cabometyx and Opdivo versus 13.7% of patients with sunitinib, an important characteristic to note for a symptomatic patient in front of you. Lastly, when we review the 5-year minimum follow-up analysis of the ORR results, you see here that ORR was once again similar to the primary analysis in patients in the Cabometyx and Opdivo arm compared with those in the sunitinib arm, about 55.7% versus 27.4% respectively. Of important note, 13.9% of patients achieved a complete response with Cabometyx and Opdivo versus 4.6% with sunitinib. For all adverse events in the primary analysis, we see that some of the highest rates for Cabometyx and Opdivo relative to sunitinib are hepatotoxicity, rash, pruritus, and diarrhea. The majority of adverse events were grade 1 and 2. For grade 3 or 4 adverse events, the highest rate in the Cabometyx and Opdivo arm versus sunitinib was hypertension at 13% versus 14% with sunitinib. Now, let's look at lab values worsening from baseline and occurring in more than 20% of patients. The most common all-grade lab adverse events in the Cabometyx and Opdivo arm were increased ALT, increased AST, and hypophosphatemia. It is worth mentioning that no new safety signals emerged in the long-term follow-up that was reviewed earlier. The tolerability of this regimen is further supported by the discontinuation rates seen in the study. Only 6% of patients had to discontinue both Opdivo and Cabometyx. 8% had to discontinue Cabometyx, and 7% had to discontinue only Opdivo, versus 16.9% with sunitinib. These safety and tolerability results are obviously very important factors in our treatment choices for patients. As mentioned previously, approximately 80% of patients in CheckMate 9ER had 2 or more sites with metastases. Since not all TKI and IO combination therapies have overall survival data by sites of metastases available, I find this exploratory analysis interesting. Let's review each set of data. When we look at the 5-year minimum follow-up for overall survival in patients with, but not necessarily limited to, bone metastases, the median overall survival with Cabometyx and Opdivo was 34.8 months compared to 20.7 months with sunitinib. In patients with liver metastases, the median OS with Cabometyx and Opdivo was 37.6 months compared to 22.1 months with sunitinib. And in patients with lung metastases, the median OS with Cabometyx and Opdivo was 47.5 months compared to 32.4 months with sunitinib. It is important to note that these exploratory subgroup analyses were not powered to show differences between treatment arms, and no formal statistical testing was performed. So, the results should be considered hypothesis generating. I believe the results of this follow-up analysis are noteworthy, especially since patients with bone and liver metastases typically have a poor prognosis. The results in this group are similar to what we have seen in the intent to treat population. Finally, we will continue to review data from the CheckMate 9ER clinical trial, including dosing and other exploratory analysis, such as PFS and ORR data in patients with grade 3 or higher treatment-related adverse events and quality of life considerations. Shown here are outcomes observed in Cabometyx plus Opdivo versus sunitinib in patients with grade 3 or higher treatment-related adverse events that were proactively managed. This post-hoc exploratory analysis evaluated the impact of timely and proactively managed adverse reactions on efficacy outcomes. Because this is a post-hoc exploratory analysis, it is descriptive in nature. No statistical procedure was employed, and results should be considered hypothesis generating. However, importantly, patients who experienced grade 3 or higher treatment-related adverse events had a similar median PFS and ORR as the intent to treat population. The key, of course, is timely and accurate adverse event management. Quality of life for patients is another critical factor for me, knowing patients may be on therapy for an extended period. FKSI 19 is a questionnaire used to measure patient-reported quality of life. FKSI 19 total score is comprised of several subscales. Although there is not one gold standard to quantify the significance of changes in the FKSI 19 score, from my perspective, a change in the score is likely to represent a meaningful change in a person's quality of life. I was pleased when I saw the exploratory patient-reported quality of life data from CheckMate 9ER. The purple line, representing the Cabometyx and Opdivo patients, generally remained stable for over 1.5 years, indicating that the mean score was maintained throughout treatment. Please note, although this is a pre-specified exploratory endpoint, the clinical significance is unknown. Another exploratory analysis from the disease-related symptom subscale of the FKSI-19 includes 9 questions intended to assess disease-related symptoms. Although the clinical significance is unknown, looking at the purple line representing Cabometyx and Opdivo, you see that the mean score improved above baseline after week 7 for over 1.5 years. Lastly, let's look at the dosing. Cabometyx is a 1-tablet dose even if dose adjustments are needed. We all, of course, appreciate single tablet dosing of Cabometyx, which may help make it simpler for our patients. Furthermore, in CheckMate 9ER, of the patients who needed to reduce their dosage, most required only one dose reduction, and the overall efficacy results were achieved even when dose adjustments were needed. As a final endorsement for my treatment choice, the NCCN has given Cabometyx plus Opdivo a Category 1 recommendation for patients of all IMDC risk groups, favorable, intermediate, and poor risk, in the first-line treatment of clear cell renal cell carcinoma. And it's also a preferred regimen for non-clear cell renal cell carcinoma with a Category 2A recommendation. In conclusion, reviewing the data from CheckMate 9ER gives me confidence when considering Cabometyx and Opdivo for appropriate patients, because this combination offers a balance of data, including superior overall survival versus sunitinib, safety, tolerability, and exploratory patient-reported quality of life. Thank you for joining me for this video. I hope you find the information presented will be useful in your practice. Please stay tuned to hear important safety information for Cabometyx.
Indications. Cabometyx, cabozantinib, in combination with nivolumab, is indicated for the first-line treatment of patients with advanced renal cell carcinoma, RCC. Cabometyx is indicated for the treatment of patients with advanced RCC. Important safety information, warnings and precautions. Hemorrhage. Cabometyx can cause severe and fatal hemorrhages. The incidence of grade 3 to 5 hemorrhagic events was 5% in Cabometyx patients in RCC, HCC, and DTC studies. Discontinue Cabometyx for grade 3 to 4 hemorrhage and before surgery. Do not administer to patients who have a recent history of hemorrhage, including hemoptysis, hematemesis, or melena. Perforations and fistulas. Fistulas, including fatal cases, and gastrointestinal GI perforations, including fatal cases, each occurred in 1% of Cabometyx patients. Monitor for signs and symptoms, and discontinue Cabometyx in patients with grade 4 fistulas or GI perforation. Thromboembolic events. Cabometyx can cause arterial or venous thromboembolic events. Venous thromboembolism occurred in 7%, including 4% pulmonary embolism, and arterial thromboembolism in 2% of Cabometyx patients. Fatal thrombotic events have occurred. Discontinue Cabometyx in patients who develop an acute myocardial infarction or serious arterial or venous thromboembolic events. Hypertension and hypertensive crisis. Cabometyx can cause hypertension, including hypertensive crisis. Hypertension was reported in 37%, 16% grade 3, and less than 1% grade 4 of Cabometyx patients. In CABINET, N equals 195, hypertension occurred in 65%, 26% grade 3, of Cabometyx patients. Do not initiate Cabometyx in patients with uncontrolled hypertension. Monitor blood pressure regularly during Cabometyx treatment. Withhold Cabometyx for hypertension that is not adequately controlled. When controlled, resume at a reduced dose. Permanently discontinue Cabometyx for severe hypertension that cannot be controlled with antihypertensive therapy or for hypertensive crisis. Cardiac failure. Cabometyx can cause severe and fatal cardiac failure. Cardiac failure occurred in 0.5% of patients treated with Cabometyx as a single agent, including fatal cardiac failure in 0.1% of patients. Consider baseline and periodic evaluations of left ventricular ejection fraction. Monitor for signs and symptoms of cardiovascular events. Withhold and resume at a reduced dose upon recovery, or permanently discontinue depending on the severity. Diarrhea. Cabometyx can cause diarrhea, and it occurred in 62%, 10% grade 3, of treated patients. Monitor and manage patients using antidiarrheals as indicated. Withhold Cabometyx until improvement to less than or equal to grade 1. Resume at a reduced dose. Palmar-plantar erythrodysesthesia, PPE. Cabometyx can cause PPE, and it occurred in 45% of treated patients, 13% grade 3. Withhold Cabometyx until PPE resolves or decreases to grade 1. and resume at a reduced dose for intolerable grade 2 PPE or grade 3 PPE. Hepatotoxicity. Cabometyx in combination with nivolumab in RCC can cause hepatic toxicity with higher frequencies of grades 3 and 4 ALT and AST elevations compared to Cabometyx alone. With the combination of Cabometyx and nivolumab, grade 3 and 4 increased ALT or AST were seen in 11% of patients. Monitor liver enzymes before initiation of treatment and periodically. Consider more frequent monitoring as compared to when the drugs are administered as single agents. Consider withholding Cabometyx and/or nivolumab, initiating corticosteroid therapy, and/or permanently discontinuing the combination for severe or life-threatening hepatotoxicity. Adrenal insufficiency. Cabometyx, in combination with nivolumab, can cause primary or secondary adrenal insufficiency. Adrenal insufficiency occurred in 4.7%, 15 out of 320, of patients with RCC who received Cabometyx with nivolumab, including grade 3, 2.2%, and grade 2, 1.9% adverse reactions. Withhold Cabometyx and/or nivolumab and resume Cabometyx at a reduced dose depending on severity. Proteinuria. Proteinuria was observed in 8% of Cabometyx patients. Monitor urine protein regularly during Cabometyx treatment. For grade 2 or 3 proteinuria, withhold Cabometyx until improvement to less than or equal to grade 1 proteinuria. Resume Cabometyx at a reduced dose. Discontinue Cabometyx in patients who develop nephrotic syndrome. Osteonecrosis of the jaw, ONJ. Cabometyx can cause ONJ, and it occurred in less than 1% of treated patients. Perform an oral examination prior to Cabometyx initiation and periodically during treatment. Advise patients regarding good oral hygiene practices. Withhold Cabometyx for at least 3 weeks prior to scheduled dental surgery or invasive dental procedures. Withhold Cabometyx for development of ONJ until complete resolution. Resume at a reduced dose. Impaired wound healing. Cabometyx can cause impaired wound healing. Withhold Cabometyx for at least 3 weeks prior to elective surgery. Do not administer for at least 2 weeks after major surgery and until adequate wound healing. The safety of resumption of Cabometyx after resolution of wound healing complications has not been established. Reversible posterior leukoencephalopathy syndrome, RPLS. Cabometyx can cause RPLS. Perform evaluation for RPLS and diagnose by characteristic finding on MRI any patient presenting with seizures, headache, visual disturbances, confusion, or altered mental function. Discontinue Cabometyx in patients who develop RPLS. Thyroid dysfunction. Cabometyx can cause thyroid dysfunction, primarily hypothyroidism, and it occurred in 19% of treated patients, 0.4% grade 3. Assess for signs of thyroid dysfunction prior to the initiation of Cabometyx and monitor for signs and symptoms during treatment. Hypocalcemia. Cabometyx can cause hypocalcemia, with the highest incidence in DTC patients. Based on the safety population, hypocalcemia occurred in 13% of Cabometyx patients, 2% grade 3, and 1% grade 4. Monitor blood calcium levels and replace calcium as necessary during treatment. Withhold and resume Cabometyx at a reduced dose upon recovery, or permanently discontinue Cabometyx depending on severity. Embryo-fetal toxicity. Cabometyx can cause fetal harm. Advise pregnant women of the potential risk to a fetus, and advise females of reproductive potential to use effective contraception during treatment with Cabometyx and for 4 months after the last dose. Adverse reactions. The most common, greater than or equal to 20% adverse reactions are Cabometyx as a single agent, diarrhea, fatigue, PPE, decreased appetite, hypertension, nausea, vomiting, weight decreased, and constipation. Cabometyx in combination with nivolumab, diarrhea, fatigue, hepatotoxicity, PPE, stomatitis, rash, hypertension, hypothyroidism, musculoskeletal pain, decreased appetite, nausea, dysgeusia, abdominal pain, cough, and upper respiratory tract infection. Drug interactions. Strong CYP3A4 inhibitors. If co-administration with strong CYP3A4 inhibitors cannot be avoided, reduce the Cabometyx dosage. Avoid grapefruit or grapefruit juice. Strong or moderate CYP3A4 inducers. If co-administration with strong or moderate CYP3A4 inducers cannot be avoided, increase the Cabometyx dosage. Avoid St. John's wort. Use in specific populations. Lactation. Advise women not to breastfeed during Cabometyx treatment and for 4 months after the final dose. Hepatic impairment. In patients with moderate hepatic impairment, reduce the Cabometyx dosage. Avoid Cabometyx in patients with severe hepatic impairment. Please see accompanying full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.